All right, let's talk about insomnia. It's a complaint you're going to hear pretty much every single day in the pharmacy, but honestly, it's one of the trickiest things to manage well. We're not just talking about a lack of sleep here. This is a full-blown disorder that can seriously impact a patient's entire life. So in this explainer, we're going to build a solid clinical framework so you can tackle it with confidence.
So let's start with a really critical distinction. The clinical definition of insomnia isn't just about how many hours someone sleeps. The absolute key here is the consequence. The sleep problem has to cause significant distress or impairment. That's the line in the sand, you know? It's what separates just a few bad nights from a true clinical disorder that needs our attention.
The very first question you've got to ask is always about duration, because it sends you down two totally different paths. Are we talking about short-term insomnia, less than 3 months, maybe tied to a specific stressor? Or has it been going on for 3 months or more, at least 3 nights a week? Because if it has, we're dealing with chronic insomnia. And that's a whole different ballgame that needs a much bigger strategy. So here's our game plan. We'll start with how to properly diagnose and investigate this. Then we'll build the foundation with non-drug therapies. From there, we'll open up the pharmacologic toolbox and look at approved agents, then dive into the tricky world of off-label and OTC use, and we'll wrap up by looking at how to manage insomnia in some really important special populations.
First up, we have to get the diagnosis right. Before we even think about a single treatment option, we need to know exactly what we're dealing with and what success actually looks like for our patient. Now this, right here, is a huge mindset shift. Patients will come to you asking for more sleep, but our primary clinical goal isn't just more hours of sleep. It's to improve their daytime function. We're trying to cut down on that fatigue, improve their mood, and just help them feel better while they're awake. Better sleep is the tool we use to get there, but it's not the ultimate goal itself. Okay, so that brings us to the big question. When a patient comes to you and says, "I can't sleep," what's our systematic approach to figure out what's really going on? A really thorough sleep history is your #1 tool. You got to be a bit of a detective here. We need the when and how long, but we also need to know how it feels to them. And crucially, you have to dig into their behaviors. Are they working in bed? Doom scrolling at 2 a.m.? We also have to screen for other sleep disorders, like sleep apnea or restless legs. And finally, how are they coping during the day? Chugging coffee? Taking naps? All of this is vital information. This algorithm here is basically our roadmap. See that first branch? It's clear, acute or chronic. If it's chronic, the next critical step is to check for comorbidities. Is this primary insomnia, or is the sleep problem just a symptom of something else, like depression or anxiety or maybe even uncontrolled pain? Getting this right changes absolutely everything about our approach. Now, to add a little more depth to our history, we've got a few tools. A simple sleep diary is fantastic for getting the patient's perspective. Standardized questionnaires, like the Insomnia Severity Index, help us put a number on the problem. But let's be crystal clear about the big one, polysomnography, the full-on sleep study with all the wires. That is not a routine test for insomnia. We only pull that out when we're hunting for something bigger, like sleep apnea. So we've got our diagnosis. Now, where do we start with treatment? Well, this brings us to the absolute cornerstone of managing insomnia, non-pharmacologic therapy. And listen, this isn't some optional add-on. This is the foundation that everything else is built on. I really want this to sink in because it is probably the single most important principle we're going to talk about. Behavioral interventions are the foundation. Before a prescription is even on the table, this is where we have to start. It's a massive shift away from that pill for every ill mindset. And the gold standard here is something called cognitive behavioral therapy for insomnia, or CBTI. It's got a few different parts. Stimulus control basically retrains the brain to associate the bed with sleep, and only sleep. Sleep hygiene is about creating the right environment. Then there's sleep restriction. Now this sounds kind of weird, right? We limit their time in bed to actually build up their natural drive to sleep. It really works. And finally, relaxation and cognitive therapy help tackle that racing mind and the anxiety that keeps the insomnia cycle going. These sleep hygiene tips are your bread and butter for counseling. The main idea is consistency. Same bedtime, same wake-up time, 7 days a week. We also focus on getting rid of things that mess with sleep, like long naps or late afternoon caffeine. And the big one that almost everyone breaks, the bedroom is for sleep and intimacy. That's it. No work, no TV, no scrolling on your phone. It's all about reinforcing that connection in the brain. Bedroom equals rest. All right, so with that solid behavioral foundation in place, now we can responsibly talk about medication. While CBTI is always first line, there is definitely a role for pharmacotherapy. So let's open up the toolbox and look at the approved agents. But always remember, they work best when you combine them with, not replace, those behavioral strategies.
Okay, this is where it gets really interesting for us as pharmacists. The Z drugs, zopiclone, esopiclone, and zolpidem, all hit the same general receptor, but they are not the same. It all comes down to their different binding affinities for the various GABA-A alpha subunits. See how zolpidem has a high affinity for alpha-1? That's what gives it such a potent, hypnotic effect with fewer of the other effects. This isn't just trivia, this is molecular detail that directly tells you how the drug will act in your patient.
So, how does that science translate into what you tell your patient? Well, with zopiclone, you got to warn them about that classic bitter or metallic taste. For ezopiclone, it's a hard and fast warning. Wait at least 12 hours before driving. Zolpidem has a shorter half-life, so that warning drops to 8 hours, but you also have to remember it's a controlled substance. And for all of them, the risk of complex sleep behaviors like sleep driving is a counseling point you can never, ever skip.
Now, beyond the Z drugs, we've got other important options. Temazepam is a solid benzodiazepine for short-term use. Then there's a newer class, the DORAs, like limborexant. Their mechanism is really cool. Instead of sedating you, they work by turning down the wakefulness signals in your brain. And then there's doxepin. At these super low doses, it's not really acting as an antidepressant. It's a very selective histamine blocker, which makes it a fantastic choice for sleep maintenance, especially in older adults, without all the usual TCA side effects.
Okay, now we're stepping into the gray area, the reality of everyday practice, off-label drugs, over-the-counter options, and natural products. This is where your clinical judgment as a pharmacist is really put to the test. Using medications off-label can make sense, but there has to be a reason for it. For a patient who also has depression, maybe trazodone is a good 2-for-1. For someone with fibromyalgia, gabapentin could help with both the pain and the sleep. But here's the critical point. These drugs should not be used for primary insomnia. You would never use something like quetiapine for a patient without a psychiatric diagnosis. The risk of metabolic side effects is just way too high.
And let's have a serious talk about the OTC aisle. Antihistamines like diphenhydramine, we strongly discourage them, especially in older adults. That high anticholinergic burden can cause confusion and next-day grogginess. It's just not worth it. For natural products, melatonin has the most evidence behind it, but even then, the effect is pretty modest. As for cannabis, there's just not enough solid evidence yet to recommend it routinely. We have to stick to the evidence. Okay, for our final section, let's adapt our approach. How does our game plan change when we're dealing with kids, the elderly, or patients who are pregnant? In these cases, that risk-benefit calculation gets a lot more complicated. Across all these different groups, there is one constant. Behavioral strategies, CBTI, that is always, always first line. In children, melatonin might be an option, but antihistamines are a definite no. For our elderly patients, we pivot to safer choices like low-dose doxepin or limborexant to cut down the risk of falls and confusion. In pregnancy, CBTI is ideal, but if you absolutely need a medication, zopiclone or trazodone could be considered. And finally, for breastfeeding mothers, occasional use of a short-acting Z drug seems to be relatively safe. So, to wrap this all up, let's distill it down into some key exam pearls. Number 1, always, always screen for comorbidities. Number 2, set realistic goals that focus on daytime function. Number 3, when it's time to stop a hypnotic, taper it slowly. And number 4, remember that chronic insomnia isn't just annoying, it's a major risk factor for developing mood disorders down the line, so treating it effectively is a form of prevention. And that really leaves us with a huge question for our own practice. We know the risks of long-term medication use. We also know that it can be really hard for patients to get access to proper CBTI. So, how can we, as pharmacists, find that balance and champion a smart, harm reduction approach for our patients? Answering that is one of our most important challenges.